It's a new. All right. Hey man. What case?
We try.
Just click on the PowerPoint. Will not be joining us. He's at SAEM, so you guys are stuck with just me. Sorry. So I went through cases honestly mostly last night and earlier today for stuff, but I did pick up a couple things for us to go over in regards to similar pathology over a couple cases, and then there was a couple things that were sent in specifically for discussion for us to look at. Number one was there was a call that was sent in where there was pre-notification for a tourniquet that was up on a limb. And the tourniquet that was up was the blue IV tourniquet as opposed to a cat tourniquet. It was the thing that was wanted to be relayed back to from that is that any tourniquet that's listed as being up is presumed by the hospital to be like a cat tourniquet. And with those, it changes it to a trauma stat activation. Which if you have that tourniquet up is great because it gets you your trauma surgeon, it gets you OR ready to go, gets a lot of things moving in the hospital, including like they'll prep the level 1, other things like that to help take care of this presumably really sick patient. But if it's not a cat tourniquet, that is something that pulls resources from the hospital, and patients can get charged for that pre-hospital notification if it's not, even if it's not necessary, just having that pre-notification done. UC downtown, trauma stats can be like $20K easily. So that was one of the reasons it was fed back, was just for resource utilization. My understanding is that the crew that had this, there was some discussion that there was trying to control some some bleeding with this, and attempted using the cat tourniquet for it. When Chief Woody and I talked about it, what we said is that if you have like some bleeding you're trying to control, these suck because you just can't get great vascular compression with it. So if you need to do bleeding control for any bleeding site, the escalation really kind of is like compress it if you can. If you can't, or if you can, try packing it, combat gauze. Israeli dressing is another one that you can do, something that actually helps get a real true pressure dressing on that area. And then the cat tourniquet is like the last resort thing that you pull out if you cannot get it to stop or just true arterial bleeding. That can happen, including with things like dialysis, fistulas, trauma being some of the biggest ones. So if that's the case and you need to use a cat, absolutely go for it. But this was just one of the things that we needed to feed back from it.
And just one point to mention here, I had talked to the crew after this came back into us. And it was explained that they had forgotten about the Israeli bandage that we carry. So make sure that we're looking through our equipment, and then I take all these pieces and then talk to Bureau Chief Roach about ways that we can incorporate these things into training. Because if we don't use it, or if we're not messing with it, we will forget it. And that is understood. So moving forward, it was one highlighting that this had occurred. The reason that they had used this was for direct pressure. To utilize.
Yep. So there was a new documentation format that I ran into this month that I haven't really seen much before. I think it might be from some of our newer medics. I actually liked it when going through as a medical director reading it. So I brought it up because what I liked is it pinpointed kind of demonstrated like the chief complaint, primary assessment of the patient, like ABC, so you get a good quick picture of what this patient looked like. They actually even included the first set of vitals in the narrative, as well as the interventions. So going through from like a medical director, and I would presume a billing standpoint, as well, was actually pretty helpful. My one thing though with it is what I did not see mentioned in this was much of a discussion component. I am a huge advocate for whenever you write a narrative, make sure that you help tell me, the person reading it, why you did what you did or why you did not do what you did. And we'll talk about it in a couple cases later on in this, what I mean by that. But the big things that I want is help me understand your thought process from looking at the patient. Like, you know, we decided to remove a patient from the home due to someone swinging a butcher knife around. Like those types of things are helpful. Or this patient, though they were bradycardic, there was no signs of hemodynamic compromise. They're maintaining appropriately. Thus, we did not pursue atropine in accordance with protocol. The areas where that really comes up and can actually help save, kind of help cover your butt, as well as like help justify things for me on the back end as a medical director, is when you have things like protocol deviations or where you're not advancing down the protocol. So say take a bradycardia patient, which did not come up this month. If you have a bradycardic patient who you decide not to pace, but instead decide to give epinephrine for them. That is listed as a deviation from Southwest Ohio protocol because it talks about atropine and then going on to pacing. So I would want to have an understanding of what your thought process is with that. If you tell me this patient's in fluid cardiogenic shock, my thought was that this person was vasodilated, I don't know, they got stung by an bee on top of vasogenic shock. And then by giving them epinephrine, I was trying to fix their bee sting reaction. That helps me understand what was going on with this patient. And that way too, if there's any questions that arise, I know what you were thinking as a person on scene. Similarly, like why you didn't go further down a protocol. So we gave this patient atropine, their heart rate went up, and they had improvement of mental status and thus did not, and they did not become bradycardic again, so we didn't need to go on to pacing. Helping like understand the thought process ends up being really beneficial. And as always, please intercede with any questions. I am more than happy to go over them. This was a third thing that was asked to go over, and is this concept of guardianship. My understanding is that there's a couple people in the township who have this legal designation of having a guardian. And this is something we don't run into all the who have been declared by the court to not have the ability to make decisions for themselves. And this can be in a couple different realms. In guardianship, that is in the setting of medical decision making. There is something called conservatorship, and that was what Britney Spears had. Her dad was her conservator, and that's a financial side. So her dad controlled all her money. She was deemed by the court not to be able to handle her money because of her mental breakdowns, etc. And that's what the whole like court case was a couple years ago, where she went to court to try to like get back her legal competency to control her own finances. Guardianship is kind of similar, and it's usually for people who they either have diminished or have lost their ability to manage their own medical things. And there's a big process that goes into getting a guardian appointed for you. You usually need like a couple of physicians that go through and evaluate these patients from a psychiatric, neurological, other standpoint, demonstrating that these patients, though they may be able to say like things that they want or don't want, they really don't have a true ability to comprehend the consequences of that. So the big reason that this comes up is that if you have a patient who does have a guardian, they do actually have the medical authority for these patients in regards to can these patients be transported, treated, etc. Hence the South Park small meme up there. This was going through my head while I was putting this together. You will respect my authority. Where these guardians actually do have the ultimate decision-making power, and usually they are appointed because they have an understanding of their patients or their family member, typically their underlying medical condition. There are some scenarios where there may be a court-appointed guardian that is just someone appointed by the state. You often see that for people who adults in the group home where their family members had passed away. No one else was able to be appointed for it. In those cases, there's usually some set process of how you get in contact with the guardian. What it really means when we're on the ground with it for these patients is that if you have them if you don't have the guardian there, do the right thing for the patient. But if the guardian is there and telling you something that might be contradictory to the patient, make sure that we have that discussion with the patient's guardian, and respecting their medical decision ability or making ability for the patient.
We need to see documentation on that, or how does that work for when the medics go out?
Most of the time I would think, trying to remember, Woody, most of these are oftentimes verbal, but they may have documentation just like a DNR, because it's a legal thing. So they should be able to at least produce something that demonstrates it. That's my understanding anyway.
Yeah, they should have something that demonstrates this, and the thing that I always wanna educate and recommend to our personnel is if something does come into question, don't be afraid to get on the phone with online medical control.
Yes.
If presented with these types of cases, right, we've all been presented with I'm the power of attorney. Well, people don't understand what that really means of like, this patient has capacity, this patient can make their decisions. That power of attorney form doesn't come into place until this is absent.
Yes.
Treat these people but we're trying to get ahead of this before we work to have an issue. I know of one in particular, within the township that, and I gotta figure out what the address is. I don't know the current address of it, so we can make it listed. But they have guardianship, and so me and the docs in one of our Monday meeting discussions.
If they've gone out, so I'm my parents' power of attorney if they suddenly dropped in front of them. But I would have to go to court to be made my parents' guardian. It's a different process, so just at least want to make sure we went over that.
So I have a follow-up question for us.
Yes.
Like, typically, we'll ask our alertness and orientation questions to determine if a person can make decisions for themselves.
Yep.
But if someone is claiming that they're this patient's guardian,
Mhm.
and that patient is still able to answer those questions, so they appear to have capacity, we would need legal proof that they're the guardian, right? We can't just take their word for it.
I would probably say yes, or at
Because
least
this
some
person's
type of.
saying they want one
Yes, and that
person
is.
there, and then this person's saying, I'm
Yeah.
their guardian, you don't listen to them, listen to me.
Yeah, I would probably say like try to get some legal confirmation from these patients, and again, like Whitney said, we've only seen like a couple in the township. So people should be able to demonstrate that for you, or there's some type of flags, you know, which patients those are.
Hypothetically, what if they can't produce that legal documentation?
All med control, pass that buck. Yeah, make me the bad guy. Yeah, that's why I don't get paid the big bucks, but that's why. Yeah, that's why I will get paid the big bucks, because I get to be the bad guy. And you guys out of that potential legal quagmire, as it were.
We have to choose a course of action, you know, it's like, how do we choose?
Yeah, if there's questions on something like this, pass that up to med control.
Got it.
Cause we are used to dealing with this quite a bit too. Especially with like nursing home patients, adults with severe mental disability, defect, etc. So pass that buck for sure if there's questions on it. And I can't imagine certainly any docket like Westchester or most like reasonable physicians would be like, oh yeah, happy to jump in on that one, because they realize the implications of that legal part of it too. But we're a little bit more used to dealing with it because we see it a lot more. So, but yeah, great question. I love it. All right. So I had a couple cluster cases that we'll kind of go through for the next chunks of all this. Number one is the cluster of OB cases, which, good golly, there was a fair amount of them. I was actually kind of surprised. I almost feel like sometimes they've been ticking up lately too, when I go through and look at the QIC reports for the month, but there was a fair amount that ended up in my QA to review. So this one I wanted to point out is a funky case. This was a patient who was just described as sick, 38-year-old female. She's 4 days postpartum, and on top of that, it was from a C-section. She started having a bunch of belly pain, puking, vomiting, and as stuck out to me when I was going through is that her blood pressure started to go up. And the reason I bring this up is the medical condition of preeclampsia. In patients who are immediately postpartum, you can still have preeclampsia, eclampsia, all of those high blood pressure pregnancy problems, all the way through. ACOG says about 6 weeks postpartum. So 4 days out, with those high blood pressures, it would still be on my list. I most likely think that was from her getting ketamine, looking at the timeline of when she started to get increasingly hypertensive. And I think that the ketamine was given at like 1752, and then she got the escalating blood pressures at like 1601 and so forth. However, what I will tell you is that from the ACOG standpoint, blood pressures, they watch these like a hawk. I have been screamed at by many an OB for not paying attention to these blood pressures because of the potential downstream ramifications, which includes eclampsia, as well as like strokes, death, etc. So if you're starting to see these blood pressures that are staying high, and for them, their high cutoff is 140 over 95. So if you're getting higher than that, especially getting like 160 over 100, I would want to I would recommend notifying OB and give a MAG. And no OBGYN, honestly, even most ER docs would blink at it. They would think it's completely appropriate because you're seeing these severe range blood pressures that are associated with poor outcomes. One blood pressure, even in like the OB triage world, they will still repeat it to make sure that it's actually real. So if you have one that you're like, holy cow, we went from normal to 200 over 110, it's completely fine to check it like 2 minutes later, but if it's staying high, I would go towards giving them magnesium, which does fit with our Southwest Ohio protocol as well. Again, I think in this one it's more of a medication reaction, but I think you could be justified for giving magnesium and then letting the receiving hospital know because of the potential effects for these patients.
Do you think on something like this, that with them not actively seizing or anything like that, would the notification call occur first, do you think, to get a doc on the phone for a secondary type of opinion?
You could, I think you could still give the magnesium.
Okay.
In patients with normal working kidneys, the 2 grams of mag that we carry is not going to do anything. It has the potential to do benefit, and if they don't need it, they'll pee it out. Unless this is a dialysis player, those are the ones I would call for first. And the thing is that you want to do the mag ASAP to prevent it from seizing, because that's going to be your best friend to help prevent you from going further down the preeclampsia road.
Sorry, did you say we only carry 2 grams?
Is it 2 are my?
Yeah, so
right?
in the drug bags, they're already pre-mixed, right? So they're the pouches on the right-hand side, front right of the main compartment. And there's only 2 grams that are in there. Now, typically, you'll see where it says to give like the 4 grams
4 to 6.
or to give 1 gram, depending on what we're talking about.
For eclampsia, if memory serves, it was 5 IV up to 10 IM, isn't that right?
Grams?
Yeah.
Yes, for a mag load.
Yeah.
If you have it. And not,
Be sure you could give up the 4 grams but through an IV.
Yeah.
And that would be opening up both drug bags.
Would that technically be a protocol deviation then, because we don't carry it all the way up to? what the protocol to give.
Not for us, because that's what we have in drug bags. So that would be, you're still doing that bag load, and if you wanted to, you could put in your documentation per med bag stock, or like per our FC Westchester protocol. Because we will understand like what's in the drug bag. Yeah, really good question. Cool. Go on, which was great to see. It was a patient who was just in her active stages of labor. The second one, I did not, but both of them discussed like patient who was going into labor, no problems with transport. The reasons I wanted to bring these up is when you're trying to figure out how quickly this mom is going to deliver baby. And I will admit, this is a thing that kind of scares me, because I flew a mom that I probably should not have flown in the helicopter, who the whole time I was clenching everything, praying that she would not deliver this severe premature infant in the back of a helicopter. It would have just gone very poorly. So I bring this up so that if you are put in a similar situation, some things that can help give you an idea of how quickly this is going to happen, and it's good to put in documentation to kind of support some of the precautions that we begin. Number one is how close together extremely painful, and they tend to be irregular. So having like an idea of what that timing is can actually be really helpful. As well as like the degree of pain that mom is having with those contractions. Tends to be, as you get closer to junior carrying into the world, they tend to become more and more painful. Number two is, what number pregnancy is this for mom? In first time moms, if you have contractions that are about 5 minutes apart, you should be able to make it to most of the hospitals here. In a second time mom who's starting to have those, you're gonna have less time, because on that second pregnancy, you've already had stretching of the cervix. It's a muscle that you have basically stretched out once before. It's already had that, so it's used to stretching back out again. First time moms, they have to go through the whole process of making the muscle that go to hospital. So first time mom, first time mom who's having contractions 7 minutes apart, they're painful. I'm gonna breathe as an ER doc. First time mom who's having painful contractions 2 minutes apart, and is screaming with every single one, I'm gonna be more concerned. Second time mom, or upwards from there, who's having painful contractions 2 minutes apart, I'm putting gloves on, just because I've seen those progress very quickly, and most ER docs and OBGYNs will tell you on that second pregnancy on up, it is just much faster and you have less time to play with. And then the other question too is, what fluids has mom passed? Has she passed a mucus plug in the last couple of days? Did she have a bunch of leakage of fluid? Is there blood present in it? OB will care about that more so than most of the ER docs will. Like if you see it looks like poop or meconium in it, or if there's blood present. But if you can take a note of it, that is sometimes helpful. And typically moms that have already had their water break, they will be continuing to leak fluid. So if you're noticing that while you're helping mom get ready to go, that is also one thing that helps give you an idea of how much faster things are going along. The other case that came up that I did want to talk about a little bit was, this one was a 31-year-old mom who I think was just at an appointment, looked completely fine. She's at term, 36 weeks pregnant. But while she was in there, or in her appointment, they did an ultrasound and showed that the fetus had a heart rate of 76 beats per minute. And there was concern that she may have some fetal distress. So they sent her into OB at Westchester Hospital. This one, I think the management is appropriate. There's a couple things that I would want to make sure that people are aware of a heart rate that's less than 100, we consider that pretty bad fetal distress. And if they're a fetal heart rate of 60, that is a code. So anything around 60, which this fetus would have been at around 76, is pericode. And once you start seeing that heart rate drop further from there, fetal demise is pretty imminent. The only thing that can fix that type of severe fetal distress is an emergency C-section. This is an odd case, which is why I thought it'd be worth it talking about for people to have an idea of what you're looking at for these babies. And for context too, like, God forbid if you have to deliver a baby, you'd expect them to have a heart rate around 150 once they come out of mom as well. If you ever had something like this where you're being asked to transport pregnant mom, it's good to ask the sending facility, like, where do we want mom to go? Like, is the plan to take her immediately to the OR at the receiving OB area, take her to OB triage, and do they know that this person is coming? Because I have seen some cases, and I've heard of people who have flown cases where mom is having fetal distress. And you fly them in and mom goes for like emergency section, like where we will put them out, put a breathing tube in and very quickly cut and get baby out so that baby does not die, especially in a term baby. So someone like this, it would be worth noting in documentation, like we're called to bring her to OR, or like bring her to OB triage for extended monitoring versus emergency section. And then just noting if you went, lights and sirens or not, to help facilitate that end. Questions about any of those before we go to the next chunk? All right. Second one, peanuts were a common theme. First one, I did need to give kudos to a crew. I think it was the 71s too. Last month they went to a 10-month-old who got peanuts, and turns out that peanuts and baby don't mix. And this kid had true anaphylaxis. Kid got IM epi and was taken to Children's Liberty and ended up doing fine. So this was a really well-managed case. I think I actually had the chance to chat with some of the people who were on this run. And when they saw the kid, realized that this kid was in anaphylaxis, very quickly treated it, and got a very quick movement towards getting the IM epi for this kid. So kudos to that team, very nicely done. This was a second case that was a little bit odd, and I'll admit that if I was on the unit, I don't know that I would have necessarily ran to epi, but I did want to bring it up as a point of discussion. This is one where I could see, depending on what they look like when they get to the hospital, then potentially getting epinephrine afterward. So this was someone who had a known allergy to peanuts, who thought that they got exposed to peanuts through like some of the food at a restaurant, and then they started having sensation of being really short of breath, feeling like they were itching everywhere. And this patient, vital signs had a little bit of tachycardia, but no true circulatory collapse you'd see with anaphylactic shock. And this patient didn't have a rash, it had an itching sensation associated with their skin. So had this difficulty breathing and this kind of itching sensation. This patient did not get epi, this patient got Benadryl, and still continued to have some itching after that, but did have some improvement in their respiratory symptoms. I think the thought from reading through the documentation was that this patient was having a little bit of a panic attack type symptoms as well. I could see in this case, depending on who the team is, who your medical director is, saying go ahead and give epinephrine, particularly if you get this massive allergic response in your whole body that causes vasodilation, causes patients to have like bronchorrhea, ends up having bronchospasms, as well as rashes break out. The problem is that several decades ago, we found out that epinephrine was like the treatment that worked for these people. You will never, ever, ever, ever get a randomized controlled trial where people say, we're gonna give these half people with anaphylaxis epinephrine, and this other half, we're not gonna give epinephrine, because we know that epinephrine is a thing that's gonna keep them from dying. What dose, who specifically can we, spare giving it to? That is just not something that is going to be studied anytime in the next 50 years, unless we have some new ethically dubious research done again, a la Germany in the 1940s, unfortunately. So what that means is that the criteria to treat anaphylaxis is incredibly low. If there's any two-system involvement, you do absolutely have an argument to give IM epinephrine, and that is considered like one of basically the main treatment for this. In patients who have had previous anaphylaxis before, they should be able to tell you some symptoms that they've had, but just because they had, say, bronchospasm and they had a rash last time does not mean that this next time they show up, it won't be nausea, vomiting, and they'll have hives. They can have different versions of anaphylaxis present. What happens to these patients is, say you give someone epinephrine who did not actually need it. I will watch them in the ER for the next 4 hours, make sure that their symptoms get better. If they don't, I fix it. If they do, I send them home with an EpiPen and I send them to allergy testing. And they will actually get allergy testing to try to figure out what caused it and find out their actual allergy. I don't even want to have that responsibility. I have an allergist figure that out. And that's because they will do really controlled testing to make sure that this person does or does not have an allergy. So for us on the ER and EMS side, if there's concern for it, I would say go towards Epi. And you can do Benadryl on top of it, but Benadryl tends not to work for anaphylaxis. That's why we go to epinephrine first. Questions? If there's deviation for something like that, it is totally fine as well to talk about it. Or if you're not sure, it's totally fine to run it past like a med control doc. Arrests, which we have in abundance up here, as everyone has seen. I got to go on 2 arrests last time I rode up here, and the teams did incredibly well. So, and every time I read through these, I don't have moments where I shriek internally a little bit, except with overall quick happiness when I read them. Apologies, guys, 1 second. And this one I think was just overall ran quite well. Noted that it was in asystole ahead of time. Oh, I remember why I picked this one. Asystole, managed with epi, managed with compressions, ended up doing field termination, which was completely appropriate. The one thing that I did want to point out, and we'll talk about it in a minute, is that there was a tibial IO, and we'll talk about that shortly. This one was another arrest, and in this one, let's see, I think this one was actually a witness arrest, and on this one, I think this also had a tibial IO, but did also have, this was one where there was a shock, defib associated with it. Got shocked appropriately, and something happened with the med bag where there was not amiodarone in the med bag. And the team did an excellent job where they sent someone to go get the backup med bag, and this patient ended up getting the full amnio complement in a very quick amount of time. So I did want to make sure that I gave kudos out for that one. They documented, we looked in the bag and there was no amnio. And when I look at the timestamps on it, the time to go retrieve the second bag from the truck and get the amnio was quite briskly done. So huzzah to this group on the management for that. This last one that we'll talk about, this was a case of refractory VFib. So this patient had, I think it was a total of 6 episodes of VFib that were shocked. And this is a hot area in CPR research for a lot of reasons. There's a paper that came out talking about different ways of managing What we found though in the literature is if you're not having a significant improvement or getting this patient out of VFib after your third shock, something needs to be done different for them. So I want to just talk about this. We could go over some of the fun things that are in the literature. And if you're on your third shock, it is completely reasonable to talk about potentially even transferring this patient to a hospital. One of the things that we have run into is this discussion of patients potentially having like ventricular storm or electrical storming. In these, we find that these patients get a bunch of epi because they've been under arrest, get amiodarone, and due to the arrest, their heart ends up getting amped up so much on the epinephrine in particular that it just stays in an excited state, much more likely to continue being in VFib. We will actually give these patients a slug of esmolol, which is a beta blocker. And what we found is that sometimes that will help get these people out of VFib by having some attack on the AV node. That is something that we're not doing in the field. That is something that is done at a facility, at a medical center. But is a thing that can be I don't have that up here at Westchester. You could consider, in some of these patients, lytics though, giving them like TNK to try, if you're convinced this is a STEMI, say you had an EKG that had a STEMI on it ahead of time, you could potentially try lysing them in the ER. So those are some of the things that we can do for them. One of the hot topics on the literature side is this discussion of doing a vector change. Most people, when you put pads on, what's your typical placement? I'm just going to pull everyone here at the setting one. Sorry, guys. And most people do anterior lateral. Who does anterior lateral? Typically is their go-to, is the first one. So here and here. Show of hands. Okay. Who does anterior posterior is their first one? Okay. And that is, if memory serves, that is in Southwest Ohio protocol. As you start anterior lateral. Air care starts anterior posterior, mostly due to logistics of trying to put a posterior pad on a patient who's arrested inside a 4-foot square box at 2,000 feet. There was a paper that came out that showed that when you were pacing patients, there was a much better likelihood of you getting the capture if you had it anterior posterior over the left side of the chest, because that vector is going straight through the heart. There is some research that suggests that doing anterior posterior, you may have better luck defibrillating these patients because you're sending that shock straight through their left ventricle. With anterior lateral, depending on what that vector is, vector, sorry, I'm gonna try not to hit your head, from the side, you may actually completely miss the heart. So that is some discussion that has come up. Most places are not saying go to anterior posterior first. Cincinnati Fire is. I think there is an argument that can be made towards that, having seen the better capture that just in my own personal practice we get when we do anterior posterior in the hospital. What I would say is if you don't do anterior posterior first, if you're on your second or third shock and you're not having luck, swap to anterior posterior so that you try a different vector. There's a paper that came out of Canada that looked at doing vector change versus actual dual sequential defibrillation where you use 2 defibrillators. The data, when you look at the 2 of them, which one of those 2 is better, was not conclusive, but they did find that either of those 2 methods did actually have a better shot of getting ROSC on those patients. And the thought is that it might just be from actually changing the vector that you're shooting that electricity through those patients. So I say all that to say, and someone who's having back-to-back rounds of VFib, just consider after your second or third shock, if you're not having luck with it, maybe I need to change my pads, or maybe I need to think of transporting, getting some other advanced therapies on board for these pads. Questions about that at all for VFib? Okay. The other thing, and I'll see if I can pull it up on here. There is also some discussion in the cardiac arrest literature about where you put your IO. There was a couple papers that came out the last year, paramedic 2 and paramedic 3, that was looking at, is IV versus IO better in an arrest situation? I read through the papers and got to nerd out on them. And from my read through them and when you compare the two, not really. They were there's a much faster rate of medications getting to your central circulation if you put your IO in a humerus. It's a pain in the butt because you now have an arm that's flopping around, but even if you look at let's see if I can, I'll pull this up when we get to the end so people can see it. Easy IO actually put together a video where under fluoro, they put dye through a humeral IO and it gets to the heart in like 2 or 3 seconds. I will pull that up towards the end. Versus someone who is already very profoundly hypotensive, you put their medication down in their leg, you may actually take a really long time to get any of that medication up towards their heart. So there is a move in general to go towards placing your IOs in the humerus if at all possible. Maybe your first one goes in IO because the patient's squished between the toilet and the side of the bathroom. It happens all the time. But if you're like kind of waiting for your next step, like you've got your airway secure, you've got like a couple minutes in, it's worth considering for that second point of access, maybe even if you can't get an IV, looking up at a humeral head IO for those patients and trying that just to help get medications to their central system faster. This I also wanted to give people a heads up on. With the new LifePak 35s, there is this really cool thing where Ira Richards, the incoming fellow, can look at the codes and we can actually see what's going on with them. We are, there's an app on our phones, I think it is something LifeNet, where I can pull up like any EKG, take a look at the vital sign trends. Is when we're taking a look at the rhythms, go like, oh yeah, I can understand why that looks like what it is. I think this might be defib or AFib with aberrancy was one of the other things that came up when just looking at these EKGs. And we can use that to help guide resuscitation. So don't be surprised if in the next couple months with some of the new LifePaks, we start having the providers, particularly at Westchester Hospital, looking at these rhythms when it comes to determination. They can see what you guys are seeing as well. The nice thing with that too is that I can see the vital signs that are going in, so I can see your end tidal, I can see your O2 stats that are happening, which might help expedite some of those discussions on the phone too for people. People can like quickly glance through their trends as well with it. Events that happen, so like giving epi, giving bicarb, they'll pop up in there so we can see them too. And Richards and I have used this a couple times to take a look at some post-Ross EKGs. Which has also helped to like say we can't find an EKG because it's paper, at least this way we can take a look at it. And it's just so that we can help give better feedback to you guys. Wrap for, okay, I don't know if we'll get through everything today, but we'll get through, I think this next section. So abnormal breathing cases. This one, let's see. Goodness gracious, Kelly. Oh yes, I remember why I pulled this one in. So this case, as well as the next one, I wanted to bring these up because they both had kind of similar pathology. These are patients that ended up having respiratory failure. The first one was a case where it was like severe COPD that had gone to end stage where these patients had completely clamped down. And the patient was hypoxic on their home oxygen. So already a really bad COPD patient if they're on oxygen at home chronically. And when we went in the house, we put the patient on our own oxygen and quickly up titrated it to a non-rebreather, not having a lot of luck with it. Patient came out to the medic unit and then got put on CPAP, and shortly after that became completely apneic. I think that when we were able to put an eye gel in bag, get things fixed. But that one was one where, I'd love to chat with Whitney about too when he comes back. With those, we've had some discussions this year about trying to make sure we bring CPAP in with us, and if these patients look like they're not improving, putting them on CPAP in the house before going out to the ambulance. Similar one actually with this one, and I applaud the team who took care of this patient because it was one where another patient was tripoding, having a lot of difficulty breathing, and they did lung auscultation, found this patient had RALS. The patient was also hypertensive, like 150s over 80s, and they determined that this patient had flash pulmonary edema. So they put the patient on CPAP and gave the patient nitrogen, and patient actually started to turn around pretty quick afterwards. There is, everyone has seen like flash pulmonary edema. There's another name that's come up in the literature called SCAPE. It's like a sympathetic crashing acute pulmonary edema. Those are your patients you tend to see like incredibly elevated blood pressures with them. They are like coughing up profuse pulmonary edema. And on those patients, what we find is that the only things that fix it is you put them on CPAP and you give them nitroglycerin. This patient was on that realm. I actually looked into this for ear care, and the cutoff for blood pressure for like crashing pulmonary edema, the systolic like cutoff where it can be considered is around 160. They don't necessarily have to be up to like 200 for them to qualify for like flash pulmonary edema. So I actually think the crew did a really good job catching this and helped get the patient a lot better. So I think between both of those cases, I thought they showed good examples of where like potentially getting CPAP on these patients earlier, even sometimes in the house, may be beneficial to help turn them around a lot faster. I also think that the teams did a really good job documenting their lung exams on these patients, and would recommend making sure you take that into consideration, because right now when we don't have ultrasound, give me a few years, we'll work on it. Lung exam is gonna actually be one of your best bets to help give you an idea if this lung is full of fluid or if it's that the lung is not moving air. These two cases, yeah, not fun. Limbs and pulses. This was just a point that I had looking at two cases where had young people that had damage to extremities. This was a patient who had like a fall, had a hematoma on the ankle, but still had, they documented that the patient still had some movement of the extremity. The one thing I don't love about our EMR, and I think that it makes it look like our documentation isn't as great as it is that in the pulses section, when I look at it, all it says is that it doesn't tell me where the pulses were taken. So in a patient who you have an extremity involved, my recommendation is document specifically the pulses for those extremities. And here's why I say that. This was a case where there was a motorcycle crash, and this poor patient ended up having an obvious right ankle fracture. The team did great. Oh God, did you guys have this too? So this one was one where open fracture, and the limb, based on the description, the limb looked like it was getting a little gross. Like, so it's having purple discoloration, bone exposed. So I had a very nice mental image going through it. So applaud for that. The only thing please tell me as the reader what the pulse is in that limb, specifically that limb. When you're looking at limbs to determine potential threat to them, there's a couple of things that you really want to look at and document just for that limb. You don't have to do it for all four, but just for the damaged one. Number one is there a pulse present? And number two is the capillary refill. Based on the description from that one, I could get a picture that it was like purplish colored. I'd imagine the capillary refill is prolonged. I wasn't sure about pulse. Pulse is a great indicator of arterial flow to the limb. If that is absent, that is a like surgical emergency, potentially. material flow to the limb. So both of those are really good to document. And then the last thing is a neuro exam. Just can it feel like touch across the limb? And can they move any of the distal digits? So when I do my hand exam on patients, I'll just quickly check like radial pulse, ulnar pulse, and then have them like wiggle their fingers for me, and then run my hand over the top of their hand, and that's my quick and dirty one. If you notice anything different, like they say, oh yeah, I don't feel it quite as much on the top, you could then break it down a little bit further if you wanted to try to figure out where exactly that nervous detriment is. And then you will look like a rock star when you tell that to the docs, and they will go through and they're like, oh shoot, they're right. But those are things that I would recommend documenting for damaged limbs. If you don't have a pulse present and it like while getting it in that splint, like try to gently get it back close to its normal length. Sometimes that is enough to get a pulse back in an extremity. Have seen it, have done it. I think we have ketamine, which I've actually done on the back of the ambulance, and it does work pretty well to help with that. And then number 3 is letting the hospital know that this is a pulseless limb. That will get you a trauma stat activation at any of the hospitals in the area that, well, the trauma hospitals and the other hospitals. It will get people's sphincter toned up and get things done efficiently. I'm actually doing well on time today. Huzzah! All right, here's a couple random cases that I had going through that were fun. Number 1, someone got a Benadryl overdose, and it was a true anticholinergic toxidrome. Big words, but anticholinergics can be including, one of the biggest classes is antihistamines, which tons of people take. This patient took a bunch of Benadryl, I believe it was a suicide attempt, unfortunately. And I was very happy reading through this. The team did a really good job documenting what this patient looked like. And this patient looked like the classical teaching they tell us in medical school. So in anticholinergic toxidromes, these patients end up having basically like amping up most of their nervous system. And there's this fun little mnemonic that goes with it where they'll be blind as a bat because their pupils are completely dilated. Hot as a desert because they end up being hyperthermic to the point it can kill them. They'll be shaking, they will be dry as a bone where they will not be peeing, they'll have urinary retention, their mouth will be dried up. Red as a beet, their skin is flushed, they'll have no bowel sounds with them. And we say mad as a hatter because they end up being completely confused and they often have a tremor associated with them. And this was exactly what this patient was. If you have, like with any overdose, if you can find out what dose of medication they took, that is incredibly helpful for us. Even just knowing it was 25 milligrams of Benadryl tablet, or 25 milligram tablets the patient had versus 50 milligram tablets, or they clearly been cut in half, that is helpful for us in poison control as well, to help give us an idea of next steps for it. These patients, if you have Benadryl overdoses, which we're seeing more and more of for some reason, really the mainstay of care for them is supportive therapy. They do have a risk of seizing, becoming hyperthermic, and having tachydysrhythmias with them. So those are some of the big things you're going to watch out for them. As well as they're going to end up being, they're going to start having a lot of losses of fluids just due to this response in their body. This case was one where we got dispatched. I want to say it was Lumiere, but one of the psych facilities in the area to a patient who they had concern for overdose. The patient got like 12 of IM Narcan from them and got a little bit more from us. And the patient was still not somehow awake and alert and walking around. Look at the vital sign trend. It looks like the patient was like that in the narrative. It looks like the patient was breathing by the time that we got there, which is my little friendly reminder that like if they're breathing, we don't necessarily need to do more Narcan for them. Narcan is just to get them to remember to breathe. If we give them too much, they then start puking and having diarrhea everywhere and end up being a little bit more challenging to take care of. So as long as they're breathing with Narcan, that's really what we want it to do. Going beyond that may actually be deleterious rather than beneficial. Now, what I will tell you is if you're noticing that this patient's getting tons and tons of Narcan, it's not working, We have a new drug on the street, Trank. It's great. This is actually xylazine. And it is in this area. We have been finding it in the drugs, in the greater Cincinnati area. Xylazine or Trank, is a veterinarian tranquilizer. It is in the same category of drug as like, clonidine, it's an alpha blocker. So these patients end up looking like an opiate overdose, but, they're having this alpha blockade, and that's what's causing them to stop breathing, be sedated, etc. And we've been seeing this a lot where you give tons and tons of Narcan and they're not waking up because of the xylazine that was cut in with the fentanyl, the heroin, whatever they took. Trank is known to cause these really nasty necrotic ulcers that I have pictures up here for. So if you see someone with this, the odds are that they've been exposed to Trank, and they literally like call it like zombie skin because it turns into these huge ulcers that don't heal very well for a myriad of reasons. So if you have someone that's not responding to Narcan, this may be one of the things that's causing the problem for you. And unfortunately, the only thing we can do for Trank is supportive care. So if this patient's not waking up or responding, you may need to do eye gel, respiratory support, etc. for them. And then again, as a reminder, like for Narcan, we just need to titrate it to they breathe on their own.
Is that the sites term like that,
Yes, yeah,
like where they're doing the drugs at?
and the arms are really common, legs are common.
Did that person have any?
It's not from the documentation that I can tell. I didn't get a chance to look at their UC chart. But there's no description of anything that fit with that. This is with more chronic use where you start getting these nasty ulcers on it.
Is that more of a subcutaneous or subdermal, or is that also possible with IV infection?
Both. Yeah, are you asking like if they get the IV or if they're like IV only versus like only injecting in the skin or?
Yeah, like.
I think that causes a lot of it. I haven't had a chance to look. One thing to keep an eye out for, unfortunately.
Out of the Butler County EMS Council meeting yesterday, the coroner's office was noting an increase in just straight heroin overdoses.
Oh, great.
Too, where they found it that people are overdosing on just straight heroin where it's not laced with anything. So just food for thought for companies out and about. We may come across more of that. They highlighted a case in Hamilton and a case in Middletown that occurred on the same day that were fatal. So just aware of that. And in those meetings that I go to, there's a lot of power players from all over the county that all bring up points like this. So it's something we're continuously watching and something that I'm trying to get out to our members better. So more to come on that.
What was this last one? Oh, this one I did, was a patient who, and I think this is the last one. Yes, it is. For her pain, and she had recently had a abdominal surgery. I think it was a gastric bypass. They did a 12 lead on this patient. They gave her nitro, didn't get better with that, so then went on to treating it with fentanyl. And patient like felt significantly better, got her to the hospital. All those things were fine. The only thing I wanted to bring out was there was in the documentation they said that they didn't press on the abdomen due to her recent surgery. I have looked into this, especially in regards to patients with an abdominal aneurysm, because this is a thing that I would hate to push on and make it bleed. And it actually, in the emergency medicine literature, it says you can't do this by pushing on an abdomen. No stomach palpation is going to make things worse, unless they have literally guts that are eviscerated. So any patient who's post-op, patient who's having abdominal pain, you're worried about a AAA, it is completely fine to push on their abdomen. You're not gonna hurt anything doing that. Even in the AAA literature that I looked at, they said that some of the like almost ruptured AAAs, you're not going to force it to rupture by doing a appropriate abdominal examination. If you're trying to push all the way to your spine, you may not necessarily need to give you an idea of where the pain is at on their abdomen. But even with that, they specifically said you're not going to cause further harm on the abdomen. So if you have a patient with abdominal pain, it is okay to do that exam, especially even if you give them some pain meds and get their pain better controlled, and that helps give you an idea of where their pain is actually at, but you're not gonna make anything worse by doing it. Let me see if I can pull up that video quick. Edema and a bad COPD exacerbation, where we use CPAP, but one of the things I wondered about was us being able to do it sooner.
We do
Do we have it in?
Not everybody does.
Okay,
And if they do, they don't necessarily place them on it in the house, that's why that's always been a hot topic of mine. The whole analogy of like, hey,
Which
get
is
your
doing
head.
early versus bringing additional.
Correct.
We brought in with the.
Yep. And we've had a number of cases where people won't place them on it in the house. For a number of reasons, right, some arguably justifiable. And that being said, though. The advantage of our new CPAP that we're starting to carry. You're just putting it on the nipple part of the oxygen bottle at 10 liters per minute and it's full flow.
let me see,
We'll have to switch the screen to share that.
yeah.
Yeah, Ryan and I texted me first, I'm hoping the video is good.
So this is actually EasyIO did this with, this is the 4O. So they put a humeral IO in, and then they're using dye to show you how quickly the dye can get to the patient's heart by putting it in the humerus. So here's your dye, and this is your heart right here. And by doing a standard flush, they have it there almost instantly. So that is one argument that I would say would be a reason to look at doing humeral, particularly in arrest patients. Yes,
Question.
absolutely.
I know when you're looking for landmarks on the humeral, it is common to have the arm over the chest.
Yes.
Now that we have been utilizing the Lucas device, that is directly in that area.
Yes.
Is the landmarks the same if we take the arm that we want to IO and attach to the strap?
Yes.
The landmarking will still be the same then?
Yes, you'll still be okay there.
Okay.
Yeah.
Cause I know you don't wanna lift it over because
Correct.
it'll crack the needle.
Yeah. No, just doing that, like this, doing it with the arm over the belly does make it a little easier for you to feel that like tibial tuberosity, or that notch on the bone. So but once you rotate it out, you should still be able to feel it, or even if you needed to like move it slightly like 1 centimeter towards their back, that would be okay. You could try it, like even just practice like feeling on yourself what it feels like when you rotate that arm out. But they've shown that that works okay with the Lucas for that.
Because it just helps a lot to have that.
Absolutely, keeping it out of the way. Yeah, no, it's a great question, thanks for
That's
that.
that's one of the biggest things about that.
100%.
But you had brought up a good point, Dave, of watching the arm movement post drilling,
Yes.
because of the triangular bone acromion process that it could snap that needle right out. So when we do drill a humeral head, if it is a patient we're moving, be very, very cautious. If we're in a core, you know, we had the one occurrence years back, you and I did on the medic unit, at Cox and Liberty Way. MVA, legs were trapped, we drilled, then when we went to move that patient out of the vehicle, that needle snapped, and now you got a free floating needle around the scene. Not as much for the patient, but for us and provider safety too. Where I don't wanna see anybody getting stuck, so yeah, we gotta control that arm if we drill that humeral head, without a doubt. Outlying stations, sorry for the connectivity issues with our unstable internet here. Did you have any other questions, comments?